All right, so what we're going to discuss is whether we need a filter or no when we perform atherectomy. So I have no disclosures relevant for this talk. So right now we're not sure, because I'm sure if we take a poll in the audience, I'm sure half of you say let's use it. Some people say it makes no difference, I'm not going to use it. So it's really not sure. And one day you will do it, another day you won't do it. So the problem is we don't have randomized data on this. So how do you address this question? So one, you want to see if distal embolization, does it occur with SFA interventions, especially with atherectomy? If so, how often? What are the clinical consequences of distal embolization? Can embolic protection devices protect or prevent these DEs? And then does embolic prevention prevent any serious clinical consequences? And who are the patients who truly benefit from it? And finally, do we need an algorithm like in every single cardio or vascular practice? Now, distal embolization is known to occur with pretty much with every single step of intervention, as simply as just introducing a wire, and this has been demonstrated in some ultrasound studies. And the highest is seen in directional atherectomy as well as mechanical, and some forms of mechanical thrombectomy, especially when you have acute limb. So here's a bar graph depicting how you can recognize distal embolization. So angiographically, as you can see on the left-hand side, if you don't really look for it carefully, you don't really pick it up. But when you put a filter in, you definitely start to see. And definitely the tallest tower here is the one with the atherectomy. And then finally with Doppler, you can see it occurs with pretty much every single form of intervention. So, despite high rate of distal embolization reaching 100%, there's only a few cases which say that these are clinically significant. So therefore, it's not very universally used. And finally, there is very limited data to say that, that 2 to 3% of patients will eventually require further treatment for it once the distal embolization does occur. So, obviously, when you see this in the filter, and you always wonder, like, how come it's not clinically significant? So here's a single-center retrospective review. Basically, they looked at 818 endovascular interventions, and what they found was 3.5% suffered in situ thrombosis and 3.8% had distal embolization. And when they looked at the primary patency, they found that whether you had distal embolization or not, it did not make a difference. And similarly with assisted primary patency, and so on with secondary patency. But when you look at freedom from recurrent events, what they found was, yes, if you had distal embolization, then there's more likelihood of having recurrent events. And then with limb salvage, yes, they found that the amputation rates went up higher with significant distal embolization. And then also you can see it affects your procedure time. Your contrast volume goes up, your fluoroscopy time goes up. And then also seen in this study with Dr. Dipple, you can see that the length of stay increases. Patients get into ICU because you got to put a thrombolytic. And what's also interesting is also, apart from the procedure time increasing, not much of a difference in the total cost was this concerning thing, the mortality. And again, there's a retrospective review, it doesn't mean anything, but if you think about it, and people have done these cases and gone through this, you put them on TNK and leave them in the ICU, it does increase your mortality. As we know, ALI has a mortality as high as 10 to 12%. So this is another retrospective review from Mayo Clinic. And what they looked at is close to 836 interventions. And what they did was they compared those patients who received an EPD and those who did not. And essentially those who had increasing hyperlipidemia, CKD, and Plavix, had more likelihood of getting an EPD. And this could have been just that, more nasty PAD, and therefore, they were more inclined to use it. And obviously, if the anatomy looked very unappealing to you, more tendency to use the EPD. What interestingly they found was they looked at task A and B and found that there was no difference in primary patency, similar with task C and D. Again, no difference with regards to freedom from reinterventions. The previous one was distal embolization. This one was with respect to using embolic protection devices. So therefore, they said that yes, if you have distal embolization, your reinterventions does increase, your amputation rate does increase. But when you put them under the classification of EPD and no EPD, interestingly, they didn't find any difference. And this could be skewed because, not all the patients received it. Maybe, there was some kind of selection bias. So therefore, it gets a little confusing. And the 2 patients who did develop distal embolization had no clinical sequelae. Now, therefore, so PK and his team published this very nice algorithm, essentially, to come up with an angiographic algorithm to see who would truly benefit. So what they did was they collected all this macroemboli and sent it to the lab, and what they found was patients with higher LDL, longer lesion length, calcified lesions, instant restenosis, CTO, residual vascular disease, and poor runoff had a higher tendency to embolize. And this is the multivariate predictors, what they found eventually. And when they just analyzed only the pathology group and they tried to correlate it with the angiographic factors, and they found that these 4 factors, which you assessed angiographically, like calcium, atherosclerotic plaque, thrombus, and ISR, had a higher risk of causing significant macroemboli as seen on histopathology. So the algorithm is you assess the lesion morphology, and then you classify into this. And I'm going to kind of summarize this, and what I'm going to do is essentially, if you look at the last line, that's the summary of the algorithm, is calcified lesions, long lesions greater than 140 millimeter, one vessel runoff, CTOs, ISR, and thrombotic lesions should essentially be considered for embolic protection device. Because in interest of time, I'm going to sum it up. Thank you.